We've actually found several very interesting things. To start with, I think it's important to consider how we usually look at the ALC population or the alternate level of care population in hospital settings. I think it's fair to say that older persons in hospitals have not always been the most welcome patients there. There's a sense that individuals with long-term chronic illnesses may not be the right people to receive care in hospital settings, that they may be blocking access to those beds for younger individuals or middle-aged individuals. And so the term bed blocker was used many years ago in a fairly pejorative manner. And I think in some sense we continue to have that problem, that we see folks who are designated as ALC as being the wrong person in an acute hospital bed, and that sends, I think, a poor message about how to think about those individuals. We've been able to, with a very large data set of over 60,000 observations, begin to understand a bit better who these people are and what their needs are, and it's really quite an interesting picture. It's clear that many of these individuals have had recent changes in their health, particularly in their functional status, in cognition, and their ability to communicate with others, which is putting them in the hospital and putting them at risk of having to go to a long-term care home. But many of those changes are often amenable to intervention. We can do something about acute changes in cognitive function. Sometimes it's a delirium related to an infectious disease. It may be a result of a stroke, which can benefit from rehabilitation if provided immediately. So these are people who have had acute needs and also have important medical needs today. We've also found, though, some interesting things in terms of how the experience of those individuals in hospital beds compares with their counterparts in the community. If we use the data that we have and match the individuals based on their level of need, we found something relatively remarkable, and that's that in the community settings, when we take an individual's needs into account, you clearly can differentiate the likelihood of entering long-term care. The folks with the highest needs, most severe impairment, are most likely to end up in long-term care. But in the hospital setting, clinical characteristics, need-based characteristics, don't seem to differentiate who goes to a nursing home versus who goes back to the community from the hospital. That raises the question of, well, why is that happening? The evidence that we have so far suggests that there's a tendency to label an individual as needing to go to a nursing home irrespective of need when they're in the hospital. So there's a process that comes into play, that an older person with complex chronic health needs comes into an acute hospital. Everybody begins to worry that, oh, we have an elderly person who's going to be an ALC patient, and so very quickly the wheels are set in motion to have that person placed into long-term care. And unfortunately, there are some folks who enter long-term care from acute hospitals that don't need to go there, and that if we took the approach of trying to exhaust all options for support in the community, we may be able to have those people return to the community and live independent, happy, healthy lives back in the community. We also see some questions related to quality in this population, and one of the things that's a bit striking is that, first of all, it seems that even though assessments are done in order to get information for the nursing home placement process, there doesn't seem to be evidence that clinical intervention is being implemented based on those assessment results, because otherwise we would see that people with different needs are ending up in different places and getting different services. We don't see that. There's no differentiation in the ALC population. We also, though, found that there's actually a remarkably high rate of physical restraint use. So over 20% of ALC patients in hospitals are restrained. That's a big problem, because not only do these people have complex medical needs, and those needs are apparently not being particularly well responded to in terms of targeted intervention, the use of restraints can accelerate decline, so it can actually make it worse for the person.